right, that's working. Okay, just give him a second. All right, good morning, and apology for the Topin, just log off this one. I'm gonna log you off in this meeting and meeting to all. Okay, perfect. Good morning and welcome to the Hamilton Health Sciences Department of Medicine Grand Round for the new year. So welcome everyone, and apology for the delayed start. This was some technical issues from my account, so my apology, my mistake. I think coming back from holiday mood into running a Grand Round is a bit complex for my brain, so my apology. We have today three wonderful, highly accomplished chief medical residents who are going to speak to us today about medical treatment, the rationale behind medical treatment for COVID. This is very well timely into our fourth wave. David, Topin, and Mackenzie are probably well known to most of us who work on CTU and other specialties. So without further ado and jump into the topic, we will get started. You guys want to share your screen?
Yeah, sorry, we're just trying to get Dobin logged on here. I don't know why we're missing him in the panelist view here. You didn't get the link? Hang on a second. Let me see if I can pull up the slides here and then he can present with me. Sorry for the other delays.
Understandable. It's there were mixed up between the links, so.
In the interest of time, maybe then I'll just get started. We will sort of then bounce between us. For now, thanks for joining everyone today. My name is Dave Putman. Mackenzie and Tobin are my colleagues here. Today we're going to be talking about some of the various treatments that have been considered to date and investigated for the use in treatment of COVID-19. And I'll just put my slides up here. All right. Okay, so I'll get started on some of the, we were going to go in a different order, but we'll just sort of roll with it here. So I'll talk first about convalescent plasma. The idea behind investigations between convalescent plasma was that serum from recovered patients may include antibodies, or should include antibodies made against viral proteins or virus surface antigens, and that would presumably confer passive immunity or protection to others if we were then to transfuse them. So in this context, you'd take blood from a donor who's recovered from COVID-19, do apheresis, get then plasma, or you could take the convalescent plasma and then actually isolate specifically the immunoglobulins, that we'd call that hyperimmune immunoglobulin. And this has been studied both in hospitalized and non-hospitalized patients. And at this point in time, there's a Cochrane review that's been ongoing for about the past year or so that at this time includes 13 studies, 12 of which are RCTs, with about 48,500 participants, of whom 41,800 received convalescent plasma. And in patients with moderate to severe disease, which is to say anyone requiring any supplemental oxygen, or severe disease being anyone requiring high flow or intubation or ECMO, we have actually pretty high certainty that there's basically no effect at all on all-cause mortality up to 28 days. And there's 7 RCTs that are included in that, accounting for about 12,000 patients. So we're fairly confident in saying that convalescent plasma does not reduce all-cause mortality in moderate to severe disease, which is to say people that are oxygen dependent already. And then in terms of looking at clinical improvement as assessed by liberation from respiratory support, again, 8 RCTs address this question for about 12,000 patients, and we're fairly certain that it has little to no impact on clinical improvement. And then furthermore, looking at clinical improvement as far as weaning or liberation from ventilation, or in terms of survival, or the subgroups looking at requiring invasive mechanical ventilation. Fewer studies have looked at this specifically, but again, so less certain, but we are fairly, well, lower certainty, but again, little to no impact on clinical improvement in the moderate to severe disease. And 4 RCTs have looked at clinical worsening in terms of the needing for invasive mechanical ventilation. And again, little to no effect on reducing initial clinical worsening. So we don't use convalescent plasma routinely in individuals with moderate to severe disease. And so the other question then is, what about mild disease, or the patients that are at home, not requiring oxygen, not requiring IV fluids or anything like that? And only one RCT, so much a smaller number of patients have actually been investigated here. Oh dear, what have I done? Now we've got the proper slides up. My apologies. Sorry with technical difficulties today. Dr. Zam, it's not just you that's having summer brain. Let me just flip over to the proper slides here. Sorry. And then we can bounce back over to my colleague there. For mild disease, despite the smaller group, we're very uncertain, but there was a relative risk reduction of 0.5. But that's again, just from the one RCT with a very low study. So the other question then is, what if we take specific monoclonal antibodies just against COVID-19 or SARS-CoV-2 proteins? And a number of people have done this. So there are a number of anti-SARS-CoV-2 monoclonal antibodies that have been investigated for use in treatment of COVID-19. And the first one that we saw in Canada was bamlanivimab. That was the Eli Lilly product that was initially approved for investigational use back in November last year. At one point in time, we had about 60,000 doses in Canada or Ontario, and many of them just sat on the shelf and didn't get used. And Health Canada later issued a failure warning as it was not effective against certain strains. And indeed, the FDA also revoked authorization for its use alone, but it is still approved for investigational use in combination with others. And so there are a number of cocktails. The second one listed here, severity and indevimab, is also called the Regeneron cocktail that we've heard about people like Trump getting in the States. And it's been approved for investigational use or interim approval in Canada since June 2021. Sotrovimab is another one. This one's a GSK product that's been approved just last couple months ago for interim authorization in Canada. And in terms of the efficacy or where we actually use these, they all their monographs say that they're only indicated for treatment of mild or moderate disease, as confirmed by COVID-19. And only in those over 12 and over 40 kilos, it is not approved for use in hospitalized patients or anyone who's needing oxygen or more than their baseline oxygen. So all of these have slightly different monographs in terms of indications or where these might be used, but largely they're for people who are considered to be high risk for progression to worsening disease to be used early on in the course after initial diagnosis. Broadly speaking, that's going to be people with advanced age, irrespective of comorbidities, or younger people who have comorbidities like diabetes, cardiovascular disease, obesity, CKD, CHF, COPD, moderate to severe asthma, or who are on immunosuppressive agents or have immunosuppression at baseline. The Cochrane review that's been assembled for this, unfortunately, at this point in time, really only has the 5 individual RCTs, and each of these are only looking at one individual product. None of these have measured the quality of life or symptom severity, and the certainty of evidence for all of these is very low at this point in time. The Cochrane review determined that that the current evidence was insufficient to draw meaningful conclusions regarding treatment with SARS-CoV-2 neutralizing antibodies. But that said, we are seeing them used in the States, especially you heard about them in the clinics in the South or some of the states where they've got lower vaccination rates, and they are being used in some places in Europe as well. There are 36 ongoing studies that are investigating these that as they become reported might give us a lot more certainty and might help us guide where these might be most usefully used or if there's certain subgroups that benefit, whereas others might not. So at this point in time, there's not a strong recommendation for using these, and they're not being routinely used in Canada as far as I'm aware. Maybe I'll come back to this one after one of my colleagues. Do you want to get started back on the other ones? I'll just have Tobin jump in here and I'll get him back set up at the beginning of the slides here. Apologize for the confusion here, but I'll just have him start here.
All right, thank you everyone. Sorry again for the technical difficulties. I'm going to be talking about a few therapies, some of which that have some robust evidence and others where there's a little bit of controversy. We'll start with corticosteroids. The primary rationale for giving them is that it's anti-inflammatory and it may blunt the immune response that characterizes severe COVID infection, and is recommended for critically ill patients, which is quite broadly defined, but that's really anyone requiring more than baseline oxygen. And the major trial that defines our practice of giving glucocorticoids for moderate to severe COVID is the recovery trial. The recovery trial included all patients hospitalized with laboratory confirmed COVID-19. The intervention was dexamethasone, 6 milligrams, oral or IV daily for up to 10 days. It was open label. He compared it to patients who did not receive dexamethasone, and their primary outcome was all-cause mortality at 28 days. Important secondary outcomes including time to discharge, receipt of mechanical ventilation, dialysis, and duration or cessation of mechanical ventilation. This is a very large trial, about 2,000 patients in the dexamethasone arm, 4,300 in the usual care arm. The mean age was 66 and about a third of patients were female. About a quarter of patients were not on oxygen at randomization. 60% were receiving supplemental or non-invasive ventilation, and 16% were on invasive mechanical ventilation or ECMO. It was a very high mortality trial. About a quarter of patients died at 28 days. Now, here we have the key primary and secondary outcomes. We can see that there was a significant reduction in death at 28 days in the dexamethasone arm with a risk ratio of 0.83. Similarly, there was a reduction in invasive mechanical ventilation and a reduction in renal replacement therapy. In the subgroup analysis, we see that it was only the patients on invasive mechanical ventilation or supplemental oxygen who benefited from dexamethasone. Those who were not on oxygen did not benefit. And this is why we restrict the administration of dexamethasone to patients requiring oxygen. Next, we're going to talk about remdesivir. This is an antiviral that interferes with the activation of RNA-dependent RNA polymerase. It's recommended for moderately ill COVID-19 patients, patients on low-flow supplemental oxygen, and it may be considered for critically ill COVID-19 patients who are not receiving invasive mechanical ventilation. The ACT-1 trial was the one that was a positive trial. It looked at patients hospitalized for COVID-19 with severe disease, defined as mechanically ventilated on supplemental oxygen or even hypoxic on room air. Their intervention was remdesivir, with the comparator being patients not receiving remdesivir. Primary outcome was time to recovery, which was on an ordinal scale from 1 to 7. And the secondary outcome was mortality at day 14 and 28, clinical status at day 15, days in hospital on mechanical ventilation or supplemental O2. It was a much smaller trial, about 500 patients in each arm, also fairly young with a mean age of 59. Most patients were male, and mortality was about 12.8% for the entire cohort. Here we have the primary and secondary outcomes. We can see here that mortality is lower in the patients who receive remdesivir than those who receive placebo, with a point estimate of 0.55 through to day 14 and 0.73 over the duration of the trial. So this at first appears convincing, but then the solidarity trial that was carried out by the WHO was then a negative trial. This study looked at all patients older than 18 hospitalized for COVID-19 of any severity. Patients also received the same regimen of remdesivir. They were hospitalized. The comparison was patients hospitalized for COVID-19 not receiving remdesivir, and the outcomes were in-hospital mortality, invasive mechanical ventilation, and length of hospitalization. It was a much larger trial of 2,700 patients in both arms, similar ages. 8.9% were on mechanical ventilation at entry, and mortality was similar to the other remdesivir trial. Here we see that there's no significant difference in mortality between the control and remdesivir groups, and the curves do not separate at any point in the first 28 days. There wasn't a significant difference whether you were on mechanical ventilation or not at entry, but there did appear to be a signal for harm in patients who were mechanically ventilated who received remdesivir. So if we compare the two trials, the ACT-1 trial, the active treatment arm had a greater proportion of patients not requiring supplemental oxygen, and the placebo arm had a greater proportion on invasive mechanical ventilation or ECMO. And the trial was stopped early with more patients with incomplete data in the placebo than the treatment arm. So this may have inflated the treatment effect that was seen. And the primary outcome was also an ordinal scale, not mortality. For the solidarity trial, it was open label. There was no information on symptom onset, whereas in the ACT-1 trial, therapy was still started fairly early in the course of illness. They used an adaptive design, and they also grouped low flow and high nasal cannula patients together. Overall, remdesivir would be recommended for patients who are not mechanically ventilated, but is not a strong recommendation because there's still equipoise as far as the optimal strategy. Next, we'll talk about tocilizumab. This is an antibody against interleukin-6, which again is supposed to blunt the cytokine storm that develops in severe COVID. It's recommended for critically ill COVID patients or moderately ill COVID patients with a CRP greater than 75, evidence of disease progression despite 24 to 48 hours of corticosteroids, and they're within 14 days of admission or infection. You can give a second dose in 24 hours if the patient doesn't improve, and the recovery trial is the one that informed their practice regarding the use of tocilizumab. This study used all patients hospitalized with laboratory confirmed COVID. They used a weight-based dosing strategy, and it was open label. And their primary outcome was all-cause mortality at 28 days, with the secondary being time to discharge, receipt of mechanical ventilation, dialysis, and duration of mechanical ventilation. It was a very large trial, about 2,000 patients each arm, with a mean age of about 64, similar to our other trials of COVID in patients. The proportion on invasive mechanical ventilation was higher than in other trials, about 14%, with 41% on high flow nasal cannula or non-invasive ventilation. The mortality was very high in this trial, about 32.8% at 28 days. Here we see that there is a significant reduction in 28-day mortality among patients randomized to tocilizumab with a risk ratio of 0.85. Patients were also more likely to be discharged from the hospital within 28 days, were less likely to be intubated or die, and were also less likely to require hemodialysis. In the subgroup analyses, we can see that the treatment effect is really preserved across all subgroups, although the patients who are not on corticosteroids did not appear to benefit. And in here, there is now a meta-analysis of a variety of trials for tocilizumab that all show a convincing effect of a mortality reduction. Next, we'll talk about colchicine, which is even more controversial with even poorer evidence than remdesivir. This is an anti-inflammatory medication with diverse effects. It's not currently recommended for inpatients or outpatients with COVID-19, and it's been studied in the COL-Corona trial for outpatients and recovery for inpatients. In the COL-Corona trial, they looked at patients older than 40, diagnosed with COVID-19 within 24 hours of enrollment, which was either PCR confirmed, or if you had contact with a PCR positive patient and had symptoms, were not hospitalized, and had risk factors for severe disease. And they were randomized to colchicine, which was double-blind, placebo-controlled. Their outcomes were the composite of death or hospitalization for COVID, and their secondary were death in 30 days, hospitalization for COVID within 30 days, and need for mechanical ventilation within 30 days. It's a very large trial, 2,200 patients in both arms, a much younger population as we'd expect for outpatients, about half male and female. The 30-day hospitalization or death rate was only 5.2%. Serious adverse events were less common in the colchicine arm, but as expected, gastrointestinal adverse events were more common among those randomized to colchicine. Overall, there was no significant reduction in the primary composite endpoints, whether for death or for hospitalization. As we can see, the confidence interval includes one. But in a subgroup analysis where they looked at patients with laboratory confirmed COVID-19, there was a significant reduction in the primary composite endpoint, and this was driven by a reduction in hospitalization for COVID-19. So there may be a role for lab confirmed COVID-19 patients to receive colchicine, assuming they have risk factors for progression, assuming it's early in the onset of disease, but we don't have the evidence for this yet, as this was a subgroup exploratory analysis. The recovery trial then looked at all patients hospitalized with laboratory confirmed COVID-19. They had slightly higher doses of colchicine, and they had similar outcomes of all-cause mortality at 28 days. And then the important secondary outcomes were relating to the need for mechanical ventilation. It was a much larger trial. That's 5,600 patients in the placebo arm, and in the colchicine arm, the mean age was 63.5, and about 70% were on room air supplemental oxygen at randomization. with about a quarter on non-invasive ventilation and 4.6% on invasive mechanical ventilation. Mortality at 28 days, about 20.8%. Here, there is no significant difference in 28-day mortality between the colchicine and usual care arms. Patients were no more likely to be discharged within 28 days, and were equally likely to receive invasive mechanical ventilation or die during the study period. And in the subgroup analysis, we can see that there's really no difference regardless of subgroup in terms of the treatment effect of colchicine. We compare the two. Corona was limited to outpatients, so it was double blind, and patients started treatment within 24 hours of diagnosis. But the enrollment did end prematurely. With recovery, it was limited to inpatients, and it also included clinically suspected and confirmed COVID-19 patients, was open label, and did not have any requirement to randomize within 24 hours of diagnosis. I do think we need further studies on this for providing it early in the course of illness for PCR confirmed patients, but until we have that, there's no recommendation to provide colchicine to hospitalized or outpatients with COVID-19.
Thanks, Stephen. I'll just flip ahead back and then we can talk about therapeutic anticoagulation. So broadly speaking, pretty early on in the course of the pandemic, it was recognized that people with infections with COVID-19 had much higher risks of thrombosis. And so previously there had been other investigations in ICU and other places looking at therapeutic anticoagulation, not just for its anticoagulant effect, but also for some of its anti-inflammatory effect. There's a lot of in vitro data that suggested that heparins have anti-inflammatory and possibly actually antiviral properties. There's a list of below there, but basically looking at the heparins are thought to inhibit neutrophil activation and function, things like extravasation. They change some of the cell surface proteins on the vascular endothelium, which changes its interaction with the immune system, and also is thought to potentially prevent some inflammatory mediator expression, and may also prevent vascular smooth muscle cell proliferation. And then also in vitro, interestingly, some studies have shown that an unfractionated heparin may bind itself to SARS-CoV-2 spike protein. So there was a thought that maybe there's even a competitive inhibitor of viral entry. Regardless, people have looked into this in terms of whether or not we should be therapeutically anticoagulating as opposed to prophylactically anticoagulating patients that are admitted with COVID-19 infection. So to this end, the initial trial that studied this, and that was the results were published earlier this year, was called the multi-platform trial. And it drew from ATTACK, Active 4A, and REMAP CAP, and looked at the population of patients who were hospitalized with lab-confirmed COVID-19, and their intervention was therapeutic anticoagulation with either unfractionated heparin or low molecular weight heparins. Their comparator was usual care thromboprophylaxis, and this was a wide study in multiple different centers and countries, and as such, the comparator here was a little bit flexible. So they did standard prophylaxis, and also some places used intermediate dose anticoagulation for this study. The outcome here was a primary composite combining in-hospital mortality in addition to days free of organ support. And the secondary outcomes listed below: survival to hospital discharge without thrombosis, bleeding, survival to hospital discharge, and survival without organ support through 28 days, and survival without intubation. This study had 550 in both arms. The mean age here was about 60 years old, 70% of whom were male. In this study, they had about 80% on glucocorticoids at randomization and about 2% on tocilizumab. About 40% were on non-invasive ventilation at baseline, and invasive mechanical ventilation, about a quarter of them. In-hospital death, this is specifically sort of in the severely ill patients. In-hospital death here was 36%, and major thrombotic events were at 8.4%. So specifically looking at like ICU level ill patients, basically the trial was actually stopped early for severely ill patients because of probability of futility. So there was an adjusted odds ratio estimated of 0.83, but you can see that crosses 1 here, and it was stopped early because of the likelihood of probability of futility. Where you would expect to see an effect with therapeutic anticoagulation would be potentially most likely in the major thrombotic events or death. And here there was, again, a fairly low probability of superiority here and a reasonable probability of inferiority, but largely because of the probability of futility here, that the severely ill arm was stopped early. That said, within the severely ill patients, their sort of measure looking at organ-free support days up to day 21 in patients with severe disease did show an adjusted odds ratio of 0.8 with that confidence interval between 0.6 to 1.03 on therapeutic anticoagulation, one day versus usual care 4 days. So partly because the risk of clot, the risk of clot formation is higher in the more severely ill, it looked like that was not where we should be using this strategy. In looking at moderately ill patients, which is to say patients not needing ICU level care, so probably just on nasal prongs oxygen or low flow oxygen. More patients here, 1,100 in the therapeutic arm and about 1,000 in the prophylactic arm. Slightly younger population here, 59 years old, 60% were on glucocorticoids. This was a relatively early study, and glucocorticoids weren't as widely, routine practice or standard of practice at this point in time. In hospital mortality in this group was 7%. Major thrombotic events were less likely at 1.6%. The big thing here was that major thrombotic events or death were quite likely to have the effect here. And basically the adjusted difference in risk was thought to be notable here. Basically looking at the event rate in therapeutic dose anticoagulation here compared to usual care thromboprophylaxis. The adjusted odds ratio of percentage of patients with moderate disease who survived until hospital discharge without needing organ support in the therapeutic dose group was 80% versus 76% in usual care. And this was thought to have a probability of superiority of 98.6%. In terms of overall rates of major bleeding in patients with moderate and severe disease, as we would expect, people on therapeutic dose anticoagulation did have higher rates of major bleeding, but this was most notable in the severe disease category. So a later study called the RAPID trial has had a preprint published just this past summer, and it looked specifically further at this question, and it looked at hospitalized patients who were moderately ill with lab-confirmed COVID-19, and they defined this as having a D-dimer level above that local hospital's upper limit of normal. This, I think, was a 6 different country involved in the study. And they also had to have O2 sats less than 93% on room air, or they needed to be 2 times the upper limit of normal of their local D-dimer rates, regardless of oxygen saturation. Intervention here was, again, therapeutic anticoagulation with unfractionated heparin or low molecular weight heparins. And their comparator here was just usual care thromboprophylaxis. They didn't have the intermediate dosing group in this particular trial. Primary outcome here was a composite of ICU admission, non-invasive ventilation, invasive ventilation, or death up to 28 days, and then a long list of secondary outcomes. In terms of the therapeutic heparins arm, this is a smaller study, 230 patients or so, and about 240 in the prophylactic arm, mean age of 30, better balance between male and female with only 56% male. These is in the moderately ill group, and at this point in time, about 77% of these people were already on dexamethasone at randomization, and 5% were on tocalismo at the time of randomization, so a little bit higher rates of steroid use because this was done a little bit later on than the earlier study. Death at 28 days in this group was 4.7%, and venous thromboembolism 1.9%. The primary composite outcome showed an odds ratio of 0.69, but crossed 1. But from death from any cause, there was a reduction in the therapeutic heparins group versus the prophylactic heparins group, and the odds ratio there of 0.22, ranging in the confidence interval there from 0.07 to 0.65. And looking specifically at death or mechanical ventilation, the odds ratio there was 0.56, but again, that just slightly crossed over 1. So meta-analyzing the multi-platform trial and the RAPID trial, taken together, there was not a significant reduction in all-cause death, though there was a signal towards that. As you can see, it just barely crosses 1 here. But there were significant reductions in the composite of death or invasive mechanical ventilation, death or organ support, death or major thrombosis, major thrombotic events, ventilator-free days, and organ support-free days alive. And there was a non-significant increase in major bleeding, as you can see across this 1 here. So taken all together, this has led to the somewhat nuanced recommendation in Ontario that for moderately ill patients, therapeutic anticoagulation should be considered. It's not a strong recommendation in favor. And I think of the people who sat on Ontario's Science COVID table, I think 1/3 of them were opposed to making a recommendation in favor of therapeutic anticoagulation, and about 2/3 majority did support a recommendation in favor of therapeutic anticoagulation in the moderately ill group. There's a recommendation against in the severely ill because of the increased harms that we're seeing, and the lack of benefit in that specific group. So therapeutic anticoagulation can be considered in your moderately ill patients. So that's the patients coming in needing ward level care, newly needing low flow oxygen, and looking at particular benefits in these outcomes, not necessarily in all cause death, but in these other secondary outcomes. And then I'll pass it over to my colleague, Mackenzie Turpin, to take us to the next topics here, and I'll stop sharing. Go ahead, Mackenzie.
Thanks, David. So David and Tobin have covered the things that we should be using for COVID, as well as the things that we could consider in COVID in the right clinical context. And I'm going to turn to a few of the interventions that at this point in time in 2021, we should not be doing. The first of which is hydroxychloroquine. The thought is that, or the initial thought was that as a immunomodulating agent, hydroxychloroquine could potentially dampen down the inflammatory cascade associated with COVID-19. In addition to which, in vitro, there was some demonstration of antiviral activity by using hydroxychloroquine. However, in the data that we have so far, this is not supported in the real world, and as of right now, it is not recommended for use. One systematic review looked at adult patients diagnosed with COVID-19 who were in hospital. The intervention was chloroquine or hydroxychloroquine with or without azithromycin in a variety of regimens compared to standard of care, and the outcome of interest being all-cause mortality. This systematic review covered 14 observational studies and 3 randomized controlled trials, one of which Tobin has spoken about at length, the recovery trial, of which there were 1,500 people randomized to hydroxychloroquine in an arm. And across these studies, there was no significant effect on mortality by using hydroxychloroquine. There was a possible risk of hydroxychloroquine and azithromycin being used in combination of increased mortality. However, there weren't very robust data for that. Across the studies, there were some risk of biases as there was a bit of lack of information regarding assignment of treatment, some imbalance between the treatment arms in terms of comorbidities, age, and other use of antimicrobials and antivirals. However, in general, because the recovery trial results were so robust and the overall signal is not for benefit, hydroxychloroquine is not recommended. There was a separate systematic review and meta-analysis that also echoed similar findings to the one I just reviewed herein, that did not show a mortality benefit, nor did it show a benefit in terms of need for invasive mechanical ventilation. Presently in the United Kingdom, their equivalent of Health Canada, it has stopped any recruitment to trials involving hydroxychloroquine, and accordingly, it is not recommended for use. Ivermectin is something that is currently very popularized in the media, and particularly on social media, with folks such as Joe Rogan, for some reason, weighing in on its use in healthcare settings. It is an antihelminthic agent that, again, in vitro was thought to reduce COVID-19 replication and dampen viral activity. However, generally this would require greater concentrations in real life human beings than are achieved clinically, and to date has not shown to be of benefit. There has been a Cochrane review carried out that uncovered 14 studies, 6 of which were randomized controlled trials. They really wanted to be broad with their scope to incorporate any information available on ivermectin use in COVID-19. So the population of interest included anyone with confirmed COVID-19, regardless of any kind of demographic factor. The intervention was any dose or regimen of ivermectin compared to any of no treatment, placebo, standard of care, and any co-interventions allowed as long as they were equivocal between the two arms, with the primary outcomes of interest being all-cause mortality up to 28 days, worsening clinical status is defined by need for invasive mechanical ventilation, non-invasive ventilation, supplemental oxygen, any improvement in clinical status, such as discharge from hospital or weaning oxygen or liberation from intubation. And then as well, they were interested in adverse events given the side effect profile associated with ivermectin. So in this Cochrane review, as you can see, there's really no obvious benefit in terms of all-cause mortality, clinical worsening, or clinical improvement. The RR for all-cause mortality is 0.60. However, it's a fairly wide confidence interval that does cross 1. And in general, the confidence in the evidence is very low with significant risk of bias. This includes the fact that there are few trials, 1 or 2 in each of these outcome groups, and very few number of patients. So across these 2 RCTs in the all-cause mortality line, there are 185 participants only. One of these studies, the total number of deaths was in the single digits across both intervention groups. So they were really unable to make any comment as to mortality and the significance thereof by using ivermectin. These results here are all for inpatients being treated for COVID with ivermectin. Moving on to the outpatient setting, there's similarly a paucity of evidence with regards to the efficacy of ivermectin, and even more risk of bias with very low grade evidence. For all-cause mortality, it's really 2 RCTs. However, the confidence interval is even more broad, from 0.01 to 8.05. And similarly with clinical worsening, a confidence interval of 0.12 to 72.47 is really not definitive in any meaningful way that this result is true. And so though it doesn't seem that ivermectin is effective, the evidence and the quality of evidence that we have is quite poor. There are 31 other studies that were ongoing at the time of the publication of this Cochrane review. And so there may be some additional evidence out there that similarly does not support ivermectin use, but this will be updated on an ongoing basis. So for right now, we really can't say one way or another whether ivermectin is helpful. The issues with these studies include the fact that it's a very unclear randomization process outlined in the methodologies. It is unclear who was blinded and how they were blinded, as well as what the allocation concealment process was. There were some issues with the analyses used across the studies. And in general, as noted, there are such a limited number of studies with few total events that it's really hard to make a definitive answer. At present, however, ivermectin is not suggested for use. It doesn't seem that it would benefit patients. It has a high side effect profile and certainly cannot be recommended at this present time, though further data will be helpful in reinforcing that sentiment. Finally, turning to azithromycin as something that is not currently recommended for use, initially suggested due to its anti-inflammatory properties. And again, similarly to the other 2 interventions, having some antiviral activity against COVID-19. Though once again, through systematic review meta-analysis, did not seem to be beneficial for the treatment of COVID-19. And fortunately, we do have some more robust data to this end to support this. So in one such systematic review, again, fairly broad, covering patients with suspected or confirmed COVID. And to be included from a suspected standpoint, they had to have very high risk exposure, very close personal contact. Intervention was azithromycin of any regimen compared to standard of care. And this was with or without concurrent hydroxychloroquine, looking into all-cause mortality up to 30 days, need for invasive mechanical ventilation or cessation thereof, as well as discharge. So the results of this systematic review, again, included fairly broad, wide-covering randomized controlled trials, predominantly from the United Kingdom, including the recovery trial, of which there were 7,700 patients, principal trial, and atomic 2. Overall, through the Cochrane risk of bias tool used by this systematic review, they were reported to have a low risk of bias and fairly robust, sound methodological studies. So we can see here across the trials for either severe or non-severe COVID, using azithromycin did not have any significant effect on mortality. Nor did it appear to have any statistically significant effect on need for invasive mechanical ventilation. In terms of impact on ability to discharge folks from hospital, use of azithromycin also did not have a statistically significant impact. And this was across like many thousands of patients recruited from a diversity of hospitals in a large geographic setting. So the bottom line being, none of these studies really demonstrated significant benefit of addition of azithromycin to standard of care. Given that use of azithromycin is not without risk, there's concerns with regards to future antimicrobial resistance. There's concerns with QTC prolongation, risk of ventricular arrhythmias, especially with the concurrent use of hydroxychloroquine. There was some signal that that may cause some worsened cardiac outcomes. That overall, there's no utility in giving azithromycin, and it should not be part of the care that we provide to COVID-19 patients.
So to sort of summarize all the things that we've talked about here, this is a table that's been adopted from the most recently updated Ontario COVID-19 Drugs and Biologic Clinical Guidelines Working Group in terms of therapeutic management, and they've nicely broken it down by severity of illness. And so for your critically ill patients, that is to say your ICU level care, needing high flow nasal cannula, BiPAP, or intubation, dexamethasone is recommended, and that's a strong recommendation. Tocilizumab is recommended for critically ill patients. And this is again, specifically if they've not had response to 1 to 2 days of dexamethasone therapy and still have an elevated CRP. Prophylactic dose molecular weight heparin or fractionated heparin is recommended here. So this is a recommendation against therapeutic anticoagulation in the critically ill group. Remdesivir is not recommended in the critically ill group. And because it's thought that bacterial co-infection is very low, and from what we just heard about the evidence for azithromycin, antibiotics are not recommended in this group. Looking at the moderately ill patients, which is to say what we would see most routinely in general internal medicine, those coming into hospital, needing admission to a ward bed, needing low flow oxygen. This is again where the dexamethasone is recommended for the moderately ill patients. And even in patients who are discharged to home on oxygen, continuation of the dexamethasone for the 10 days can be considered. Therapeutic dose anticoagulation by the Ontario Working Group here, they said should be considered because of the sort of like middling or disagreement between the panel in terms of how strong the effects are that we're seeing in that, and the effect not being observed or maintained over the primary outcome of mortality. It's a consideration here. And the nuance that goes into looking at their weighing their pros and cons between risk of bleeding and risk of clots. So it's on the ward level sick that you should think about therapeutic dose anticoagulation. And then again, tocilizumab indicated just as the same as in the critically ill here for continued elevated CRP despite 1 or 2 days of dexamethasone therapy. And then unfortunately, the punchline for the mildly ill, those that we try to manage in the community who aren't needing oxygen or IV fluids, basically everything that we've tried to date has no evidence for it. There are ongoing studies that will give us a bit more information, but at this point in time, summarized in the right panel here, basically the monoclonal antibodies, there's not enough evidence to recommend them. Colchicine, again, not enough evidence to recommend it yet. More studies are ongoing, so as those get completed, we might see recommendation change for these. And these guidelines are all being continuously updated. And then we do have enough evidence to recommend against antibiotics, against the hydroxychloroquine, against the ivermectin. And then we didn't talk about some of the other ones. But if you are interested in looking at some of the other therapies that we didn't touch on today, there's some really great online resources that are continuously being updated. And a number of people from McMaster have been involved in some of these projects. The BMJ has a living systematic review and network meta-analysis. And if you want to pull this website up, you can pick whatever outcome you're interested in, and then look at any of the agents that have been studied looking at that outcome. You can hover over it, and it's just continuously updated as papers become published. If you don't mind stepping from the next slide as well. And the WHO, in association with this, also has a living guideline that's continuously updated as more studies are published. And you can see here that there's a little bit of nuance and difference between what the Ontario panel recommended here, in that the remdesivir is a weak recommendation against here, but otherwise similarly strong recommendation in favor of the IL-6 blockers, the tocalismo, and a strong recommendation in favor of corticosteroids. And again, no recommendations in the non-severe group here. And then lastly, this is another living network meta-analysis that you can look up in terms of summarizing all of the investigations that have been done to date. And it summarizes the benefits and harms and looks at the specific outcomes. And there's a big long list of different agents that have been investigated. So these are all available online and continuously updated. And I think the Cochrane systematic reviews that we also talked about are also being regularly updated as published, as new trials are published. So looking back at these regularly as more things get published will be of some value. And with that, I'd like to thank my colleagues here. And we have a long list of references. If you want to reach out to any of us, we'd be happy to send along the references, but most of these are easily searchable. And thanks to our supervisors for giving us some insight, and good luck to everyone taking care of patients in the community. We'll just pull up the Q&A here and see if there's anything that we can field.
Thank you guys for, David, Tobin, and Kinsey, for this fantastic presentation. You guys have taken a very tough topic and you presented it in a really simplified way, covering all those complicated evidence. So thank you very much. I think a couple of questions are there. The first one looks like it's been answered already, and you've given us the summary as well as the different resources. Although I continue to struggle with which resource should we follow, being practicing in Ontario, and we have the science table, but there's also emerging evidence, and you've shared us with a really excellent. The BMJ source is really a good one, and as you said, many of our colleagues are working on it. And then there's the recommendation that comes from down south, like the monoclonal antibodies, that are used down south but not used here, or maybe used here because it's available, but it's not recommended yet by the science table. How do you balance all this in current practice?
So I think specifically with the monoclonal antibodies, presumably you'd think that they would be helpful. I don't think that the strength of evidence justifies their cost, and partly in the US, I think just the economics of the health system there have changed what is seen as valuable. But that said, as more of those things get published, I think we'll see the public healthcare systems more likely to use it, because there probably is a cost-saving effect on the use of the monoclonal antibodies, especially if you can keep people from getting more severely sick and not needing to come into hospital. And so basically what you're seeing in Florida or Louisiana is a lot of those clinics are offering state-funded doses for the monoclonal antibody cocktails, in the hopes that those people don't need to end up in the hospital, don't need to end up on a ventilator, because of course, despite them being something like $2,000–3,000 a dose, that's still probably cheaper than them needing a hospital admission and a long course of treatment. So we might start seeing them used more in Ontario, but the thing that we didn't talk about here today in the big picture is that the end game for COVID is immunization, and we have tons of great evidence that vaccination is really what we need to be doing, and prevention is way better than all these treatment options. So I don't know. Evidence will change, and I think things will get updated, but I think some of the single payer systems are a little bit more conservative, perhaps, in terms of their recommendations. So I would tend to go with the Ontario specific ones, because I think the people, the pharmacists and the doctors and the people working on that specific science table, I think have Ontario specific context in mind when they're making those recommendations. But that said, there are those 3 different products that I talked about in Canada that are approved, at least for investigational use. And I think there are ongoing studies involving those. And a number of the treatments that got talked about that we don't recommend do still have ongoing studies. So some people might be involved in some of those depending on certain sites. So that's a lot of hand waving, but that's, I think, kind of where I'm at with that particular one.
Sounds real. Talking about the cost of admission, just came out the sky high to this morning that, you know, a cost of admission for COVID patients is $20,000+, and if they go to the ICU, it's $50,000+ per admission. A couple of questions as well. There's one on use of aspirin, and if there's any evidence for that. And then there's from Dr. Priptani, or the exchange of different steroids other than dexamethasone, if there's any evidence for that.
Yeah.
Okay, so for the aspirin part, it's hard for us to comment, to be honest. We didn't look specifically at the role of aspirin for the prevention of thrombotic events. I think that would certainly warrant further study. I think the concern there would be that its antithrombotic potential might not be as high as its risk of bleeding, which is still fairly high with aspirin, as well as the background of prophylactic anticoagulation that all these patients are on. But I couldn't comment further than that. As far as the other question about the interchanging with other corticosteroids, so this has been studied. The REMAP-CAP trial looked at hydrocortisone instead of dexamethasone versus placebo for patients with severe COVID, and it did find a fairly similar magnitude of effect as dexamethasone. There are a few other trials using methylprednisolone as well. So really, any steroid dosed appropriately would be a reasonable option. Like some of the biggest evidence has come from dexamethasone, and that's why the guidelines tend to be fairly homogeneous with recommending it, because it's also once daily dosing, as opposed to 4 times a day with hydrocortisone. But really, any locally available corticosteroid would be effective.
Fantastic. There's a question from Dr. Carnu around vaccination, influenza, and pneumococcal. Is there any evidence for helping other than the logical thing of preventing these diseases?
Yeah, we didn't specifically look at that in terms of our review of the evidence here, but I think it probably is reasonable to recommend this to anyone that you would otherwise. I don't know if you guys have any other insight on those particular recommendations.
Anyone from the audience have any recommendation, please type it in the chat. We're on time, and I know we started a bit late, but I really appreciate your patience this morning and your ability, 3 of you, David, Tobin, and Mackenzie, to get this done on a timely manner and cover this very important topic in a well-timed with the admissions of wave 4 increasing right now. So thank you very much. And if anyone have any other questions, you can reach out to the panelists directly or to their supervisor. Really appreciate it, and have a great day, everyone.
Everyone.
Thanks, everyone.
Thank you very much.
Thank you.